The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health and death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking, conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name is Nesh Nikolic, and my guest today is Dr Andrew Amos, who is a psychiatrist and is here to talk to us about his concerns with regards to gender-affirming care. This podcast leans into his concerns relating to the definitions of gender and sex, concerns around the assessment process of gender medicine, how young people's access to gender medicine can reinforce their confusion, legal issues such as consent, and concerns around harm being caused by some of these gender medicines provided. Many more topics are discussed, but I do want to mention that this is only one side of the conversation. Today leans into the concerns around affirming care, but it's certainly not the entire conversation. So I do want to put that forward and also note, although I don't believe it needs to be noted, that both I and Dr. Amos have great respect and kindness and consideration towards all kids that have any level of distress, challenge, confusion, identity difficulties that they are going through. And the question around affirming care or not providing affirming care is not a question of supporting children or not, but is more so a belief around what is the correct care to support and help young people, in particular, who are going through a difficult time. I hope you enjoy this episode. Andrew, big thank you for coming onto the show today. I'm privileged to be able to speak with you about, I think, a topic which is very current, particularly around, I think, psychologists and psychological care, psychiatry, mental health in general. And that is really about how we support people best. And in particular, topic today is about transgender people. How do we help them the best? And I know that you've written a paper and have views and even some concerns about the current model. And so, really looking forward to hearing more about your thoughts, and being a psychiatrist, I think a voice around the medical model about how we should view this and best care for this cohort.
Oh, thanks, Nesh. Look, thanks for having me on. I agree, it's a very important topic. It does cover a whole range of disciplines. I think of it as gender medicine, essentially. So all of the things that might be incorporated in both transgender people, but also what they're calling gender diverse people coming to the clinic, and also people, particularly young people, who might be gender confused. So there may not be a specific clinical issue there, but they're starting to think about some of the issues that might lead to transgenderism.
Might be useful to try and start our conversation with some definitions. And I know this is a challenging space in and of itself in terms of what does it mean? How do we understand what a gender is?
Yes.
Versus sex and the like. And there seems to be some confusion, at least in the current literature that I've read. I've never had that confusion personally myself growing up.
Yep.
But this new topic and I suppose medicine and the categories that we're seeing is new and different to me, and I'm finding it difficult as a health professional to navigate. So would love to hear your definitions or views or thoughts.
Well, look, it's actually got a bit of an interesting history, and the definitions are important in that history. So one of the things that affects the treatment of gender diverse people today, particularly from psychiatry, is that the original definition of what today we might call transgender was transsexual. This is 50, 60 years ago and longer. And it didn't just incorporate ideas of gender. There were also implications that it might have sexuality issues to do with that. And back then, there was the implication that it was what was called a sexual perversion. So not just today we might describe someone having a gender identity, which is the way they think of themselves in terms of male and female ideas. The idea of the transsexual was that this was something that was inherently wrong, that it had a sexual component, and that it was something that would need to be treated to get rid of it, essentially. So this is a long time ago, but very much tied up in the historical guilt of the profession of psychiatry, to do with homosexuality. And again, 60, 70 years ago, psychiatrists looked at homosexuality as a mental illness, a sexual perversion, and again, something that needed to be treated in order to get rid of what was a problem. So that's the historical background. And the definitions have changed quite a lot over time, but most recently, probably the broadest category that we think of at the moment are gender diverse people. So that would include what we would call transgender, but also other categories like non-binary. So starting with the basics then, gender is the social manifestation of sex. Most people are very familiar with the idea of biological sex. So you might be born a boy, you might be born a girl. Biological sex then are the physical features of your sexual characteristics, things like having a penis if you're a boy, having breasts if you're a girl, or a vagina. Those are biological sexual characteristics. Gender then is a socially constructed idea, and it's really the way that you present characteristics that are usually associated with biological sex, male and female. So traditionally, you might think of the male characteristics, things like being very assertive, being physically stronger, tending to take the lead in social situations. Now, some of those, of course, are stereotypes, and certainly not things that are characteristic of all males, but they are traditional ideas of gender, so social characteristics that we associate with sexual, the original sexual ideas. Gender identity then is your presentation and experience of those features of socially constructed sex. So if you think of yourself as primarily female, that doesn't necessarily have anything to do with your biology, but it might have to do with some of those stereotypical ideas. So traditionally, women would be less aggressive than males. Certainly physically, men and women look different. So gender identity then are the socially constructed ideas associated with sex. And the whole idea of gender medicine, as in the way that's currently talked about, of course, is that a person has ultimate authority over what their gender identity is. Nobody else gets to define what your gender identity is. Now, this is differentiated often with differentiated from the sexual characteristics. And one of the ways we talk about that is sex assigned at birth. So this is rather than the idea of your chromosomes determining what your biological sex is, people who take a gender-affirming approach to gender identity might think when you're first born, a doctor looks at you, looks at your secondary sexual characteristics, things like presence of a penis or a vagina, and says, this is a male baby or this is a female baby. So that's the idea of sex assigned at birth. So the idea then of gender identity, it is not constrained in any way by that sex assigned at birth. Now, I as a doctor wouldn't necessarily think of sex assigned at birth as a primary characteristic of human beings. I would think of biological sex. And the difference is sex assigned at birth is something that's variable, that's assigned by a doctor. Sex is something that is definite and can be determined by things like chromosomal analyses. Now, it is true that there are some people who don't necessarily exactly fit into the male and female categories of having two X chromosomes if you're female and an X and Y chromosome if you're male. So there are different variations, people that we call intersex. But 99% of people do have a definite sex one way or the other. So yes, gender identity then can be differentiated from sex. That then leads on to the idea of gender-affirming care, which is a model within gender medicine of treating what I would describe in the initial stages as gender confusion. So some people have a very firm idea of what their gender identity is. Most people, of course, don't necessarily consciously think about it too much. But a gender identity that is different from either your sex assigned at birth or what you might think of as biological sex, then would characterize what we call gender diversity. So if you have been born as a male and you start to think of yourself primarily in terms of female characteristics, we might then think of you as being one of the gender diverse categories. Now, transgender is the most talked about category within the gender diverse spectrum, but it's by no means the only category. And transgender essentially means someone who was born one sex, but primarily identifies with features of the other sex in a social context. So that's someone who might have been born a male, but presents themselves as female in social situations. The expectation that many people in that situation have is they will be treated as primarily female. So the way that they're treated in social circumstances won't have anything to do with their chromosomes, and there's no real good reason that it should. It will have to do with the way that they would like to present themselves. Now, of course, there's a vast diversity of ways that you can present yourself as a man or a woman. You might think of what used to be called butch lesbians, for example, a category of social gender identity different from stereotypes, but also not exactly consistent with biological sex. I feel like I've been talking for quite a long time.
It's difficult for me to hear all these terms without naturally going back into, I suppose, my understanding. You know, when I hear, for example, sex to me has always meant whether you've got a penis or a vagina. Right, so it immediately attaches to the biology.
Yep.
I haven't in my lifetime experienced that we assign a sex.
Sure.
Nor do I believe that doctors have, obstetricians have assigned. I think they have, at least my understanding, and maybe I'm a bit naive, when a baby's born, obviously considering that there might be a very small number that it's difficult to define.
Yes.
But we're looking at, I suppose, patterns and averages. Most people can understand or presume that when we observe a penis, for example, we know what chromosomes go with that, and therefore we call the child a boy or male. And that's how it's kind of recorded. It's not there's something that we are assigning either way. It's not like we're questioning that. That's never been questioned that I've observed. Not that I'm an obstetrician by any stretch of imagination. So when I hear sex, and I hear one's biology or male, I see all those things as being synonymous.
Sure.
Where I struggle as a human being and as a psychologist as well is when we start to deviate away from that. So once we start saying we're assigning, because the logic, at least for me, thinking about as a cognitive behavioral therapist,
yes,
I question these things, and so immediately in my work, the idea of assigning is challenging. Maybe this is where I'm a bit confused.
Well, look, one of the most interesting intersections in the field of gender medicine is between legal and biological definitions. It's unquestionably true that there's a legal act. When a baby is born, the assigning of sex is literally what you write on the birth certificate or the other documentation you might fill out. So in the legal sense, the way that, for example, the government thinks of you is determined by an assignation.
Okay.
Yeah, so that's a legal definition. What you're describing, of course, is the human understanding of biology which pre-exists any government.
Yes.
Yeah. So the most people live their lives having an unconscious understanding of the differences between male and female. It's not something we really spend a lot of time thinking about. What we do think a lot about is how we interact with individuals, and we will develop patterns of interacting with males and females in different ways. Now, without wanting to go into too much, of course, your early relationships are very determinative of your later relationships. And the classical idea is the first intimate bond that you form is with your mother. This is all kids. Some kids, of course, don't have mothers, and they generally will develop a substitute relationship. But the first relationship for almost all people then is with a female other. There is a father hovering around, and they will have more or less interaction with the child. But these are gendered relationships that we have from a very early stage. So I think what you're describing is very common. Most people would think, well, I know what male is, I know what female is. Most people would they wouldn't even necessarily think of this, but they would know penis means male, vagina means female. They would also have a whole bunch of other things, because of course, when you see someone on the street, you can't see their genitals, but you'd have a pretty good idea of whether they're male or female just by what sort of body they have, how they interact with people, those sorts of things. So very common. But I would make that distinction. There is a legal reason for thinking of assigned at birth. It's different from the biological. And a lot of the things I've been writing about in my articles is caused by the difference between biology and a legal definition of gender versus sex, which has all sorts of flow-on effects and causes a lot of problems. So that may be the distinction to draw that might clarify the questions that you're raising here.
And is the legal definition changing in terms of, because that confuses me?
Oh, indeed.
Again as well, because I'm sure it will play out in different spaces differently, you know, for all intensive purposes. How someone assigns their identity from a personal human perspective has no bearing on me, and I love to celebrate everybody. You know, it's a beautiful thing to be an individual and you know, find your own path through life and the like. I suppose where I get a little bit confused is how changing definitions is going to be traversed. You know, I mean, specifically, like, for example, healthcare. I believe there is different data for men and women in terms of how you physically treat them with medicines.
Absolutely,
and how you might examine them, and the like. Maybe a little bit less in psychology. Well, not a little bit, completely less, because we don't really aren't too concerned. We're more concerned with the psychology of the person, and obviously the challenges that they might have. Obviously, affirming stuff we'll get to, because I think psychology has some strong historical understandings about how we do treatment and what we should be, how we should be supporting our clients. But I'm getting at least a challenging space in my mind about how we're going to traverse the changes of legislation, for example. I'd love to hear what some of those things have been.
Look, I think it's simplifying to think of gender affirming care in the context of what is a political movement. And I've written articles that basically say gender affirming care is not a medical model of treatment, it's a political movement that's presented as a protocol. The basic idea is the right to define your own gender identity is a basic human right. Now, it's not something that's existed throughout most of human history, but it is something that is being promoted by people also promoting gender affirming care. The way that there is a strategy as to how you might promote the idea of this as a human right. And the basic strategy is to try and get gender self-identification passed as legislation and put into legislation that is used to, for example, determine what is allowable in terms of discrimination and what's not allowable in terms of discrimination. So traditionally, it has been legal to discriminate between men and women in terms of their biology for things like female-only spaces.
Sure.
Yep. And the rationale for this was always that if you look at the patterns, there's a very high rate of male to female violence and a very relatively low rate of female to male violence. And it was thought that giving women spaces where males weren't would be positive in all sorts of ways.
Sure.
There would be less predatory behaviour, and it would also facilitate, developing their own individual interests. Sport has been a very important idea. So, for example, 100 years ago, very little in the way of competitive women's sport. More recently, of course, a very important industry, a very important part of the self-concept of many women. The idea of becoming a sportsman, getting to elite level, competing against other women. The idea of legislating the right to gender self-identity then has had the unintended consequence, we do have it in Australia, the unintended consequence that in terms of discrimination legislation, we no longer differentiate people in terms of their biological sex. We differentiate them in terms of their gender self-identity. And what that means is a biological male who presents themselves as a woman now has the legal right to force their way into what were traditionally female-only spaces. So that's a legal right that's been established by gender self-identity, and we didn't anticipate that this was going to be the result of that. You may be familiar with, it's an unusual name, but there's a case recently heard called Tickle versus Giggle. Are you familiar with the case?
I have heard of it, and it's probably only several weeks ago.
Yeah.
But I don't know how what the outcome or whether it's still to be established where that's going.
Very simply, Sal Grover is a biological woman who wanted to set up an app that was for biological women only, where they could do all sorts of things. Essentially, a social media app to support women. A transgender female, so someone who was born male but now identifies as female, essentially said, "I'm not having that," and multiple times tried to assert their right to go into this female-only space. The woman who put it together, Sal, said, "Look, just looking at you, I can tell that you're a male, and he is a biological male. I do not want you in this space. This has been set up for this purpose for these women." Now, in the traditional model, that would have been fine because you can differentiate in that older model between people in terms of their biological sex, and there's good reason for differentiating between people. In the new model, in which gender has supplanted sex, it's now a legal question. And we don't know the result of this case yet, but it looks like it might actually be decided in favour of the transgender female, and it would then probably go to the higher courts. So it's just a demonstration that the legal facts determine then safety of women. If you establish the right to this transgender female forcing his way into a female-only space, even on an app, you've then established a precedent that can be used for all female-only spaces. So changing rooms would be the other obvious example of this. So you could no longer exclude biological men who identified as female from going into female-only spaces. Prisons is another area where this is currently being contested. So biological men going into females' prisons. Now, it is true that the numbers are fairly small, but of course, once you establish a legal precedent, it can then be targeted by predatory males who say, I think of myself as a woman, I can then get into a female space like a prison or a changing room. So very important that we establish the difference between biological sex and gender, and then work out as a society what is appropriate, how we differentiate between people and what we allow them to do on the basis of this. There has been no discussion at a societal level of these types of questions. There's a really interesting an illuminating manifesto called Only Adults. Now, this is a document that was put together by Thomson Reuters, which is a publishing house, and Denton's, which is a legal firm, for the International Gay and Lesbian Youth Organisation, released in 2019. So if you search for IGLY0 Denton's Only Adults, you'll find this document, and it lays out essentially a strategy for enforcing these legal changes, despite the fact that the people who put the manuscript together realised that these are not popular ideas in general society. So what they did a whole bunch of research about ideas of gender diversity, gender self-identity, and the legal right to assert your own gender identity across the countries in Europe. They basically found people don't like these ideas if they find out about them. So what they then recommend, the strategy that you have to use, because these are not popular ideas, is you target legislators. As much as possible, avoid any scrutiny. So try not to have public cases that, like Tickle versus Gill, that make the public aware of the consequences of these things. And then focus on a few core ideas, such as getting the legal right to gender self-identity into legislation. Once you've done those things, the other rights then naturally follow. So look, I realise I've been going on a lot about legal ideas rather than psychiatric or psychological ideas. But what I'm trying to demonstrate is this has been presented as a medical protocol. Gender-affirming care has been presented as a medical protocol. But what it is, in fact, is a political paradigm. It's a political strategy. It's an attempt to enhance the rights of a certain group of people. And it is enforcing those despite the fact that they harm other groups of people. So the loss of the right to female-only spaces for women would be the premier idea that demonstrates the loss of rights to another group of people. So look, that's the legal background, the political background.
And if I can jump in,
sure.
I think the legal background is helpful for me to understand because when I think about this space, I have always associated male with, penis, with gender.
Yeah.
And when we start looking at the concept of identity, I have been completely open to identity. I have recently grown a bit of a beard, so my identity has shifted a little bit. I don't have hair. We share that in common. And I can change things. You know, my identity in a professional sense, I get dressed and I look the part.
Yes.
When I go home, my identity is very different by just even the clothes I wear, right? I'm an avid camper, so I enjoy that part, and I would
no outward signs of that, Nesh.
yeah, can tell. So I can see that I play lots of identities within my own life.
Yes.
And roles as well.
Indeed.
But I haven't seen that my gender identity is one that shifts. And I suppose what I'm hearing here is when we move from being very open to celebrating everybody's identity and making space out, because that's, I believe, very strongly associated in the compassionate psychologist and psychiatrist and medicine. When we then blur that with, you can change your gender and gender meaning sex.
Yes.
And so now we've moved it a little bit. I suppose that's where the confusion has come up, and you've kind of illustrated what happens in a prison setting, or what happens in a sport setting, or some of those very scary ideas of what would happen in a change room with predatory behavior and the like.
Yeah. Well, look, this might be a natural segue then into gender-affirming care. As you say, gender identity for everyone is changeable. Growing a beard might have an impact, and it might change the way people respond to
Sure.
Yeah,
Absolutely.
Certainly, shaving off all of the hair is an act along those lines. Now, we've talked a lot about the legal and political circumstances. Gender-affirming care then is presented as a medical model. And the basis of gender-affirming care is the idea that you have the human right to define your own identity, your own gender identity. And it goes the step further then that it is the responsibility of all health professionals, probably goes a bit further, in fact, all of society, but certainly in terms of the medical model, all health professionals must automatically affirm your self-reported gender identity. Now, this is completely different from any other medical model. It's a subjective report of an internal state, and at least in the way that it's written up, so the core principles are defined at most length in the WPATH standards of care. In Australia, it's AusPath who has written clinical guidelines to specify the model of care, but in the WPATH and AusPath clinical guidelines, gender-affirming care then is that automatic affirmation of the gender identity. Essentially what that means is you can't question a person's self-reported gender identity. Now, the essence of psychiatry, the essence of psychology, is that you question all of the things that come to you when a patient presents. If someone comes to you and says, well, I've had this very traumatic experience, and now I'm experiencing sleepless nights, I'm taking more drugs than I used to, I've started cutting myself. These are all symptoms of an illness. You would need to talk to that person as honestly and openly as you can about what the traumatic experience was, about all of the circumstances around that, and then what is the history? So have you had other traumas in your life? Were there reasons that you might be particularly susceptible to a traumatic experience and have something like post-traumatic stress disorder or a depression? It's absolutely vital that you diagnose an illness in order to be able to treat a patient. Gender-affirming care, in the way that it's written up in these documents by the WPATH and AusPath organisations, completely eliminates diagnosis. Someone comes to you and says, born a boy, I now feel like a woman. You must accept, and not only accept, but affirm that. The model then is not just what we call social transition. So social transition then is to treat that person as their preferred gender identity in social situations. Affirmation then also includes medical and surgical alternatives. So that would be providing medications to someone, hormonal medications, that changes the composition of their body. So literally that they might grow breasts if they were born male, and certainly if they're female, that would cause them to grow a beard and so on and so forth. So you're affirming subjective self-reported gender identity, not a diagnosis, based on the idea that it's their human right that you affirm their gender self-identity. Of course, the next step would be surgical affirmation, where you actually cut off functional body parts in the service of that affirmation. Now, I have written a couple of papers on this. This is not a medical model of treatment.
No.
The medical model of treatment basically is first diagnosis, then examine the evidence for treatment, and third, try and reduce the symptoms of a disease or cure a disease. The gender-affirming care model has none of those components. It doesn't attempt to diagnose. There are a couple of diagnoses that exist. So gender dysphoria and gender incongruence are diagnoses associated with gender dysphoria, with distress associated with gender, but they are not required in order to provide gender-affirming care, at least in the way that they're currently written up. It doesn't look at any of the evidence. So if you look at the WPATH and AusPath clinical guidelines, the intention of what they're promoting is not to cure an illness. It's not to reduce distress. And it isn't evaluated in terms of whether it reduces, for example, symptoms of mental illness. So the purpose is not to reduce gender dysphoria. It's literally to affirm this gender identity. That is the purpose. So that is a political purpose. It's not a medical model of treatment. So I'll be fairly clear about this in a couple of my articles. And it fits very neatly, of course, into that idea that gender-affirming care is not intended to cure illness. It's intended to promote a political agenda.
This is where I suppose I've struggled with trying to understand this space around affirming care.
Yes.
Because everything that I've learnt in university, my studies, my clinical work, my supervision with my colleagues, and how I support them, and how we look at best practice psychological care that we are required to provide, does not lean into affirming clients' experiences.
No.
Except for when we have done our assessment.
Yes.
Right. So an example might be, if a client does come in distressed, I can quite comfortably affirm that they are feeling upset, distressed. That's called validation.
Validation, yeah.
And it's at the heart of someone feeling heard, therapeutic rapport, et cetera.
Yep.
Where I'm challenged is, in psychology, we're always looking at, quite often in actual fact, challenging or questioning or querying or being curious around what someone is experiencing, and where avoidance might be occurring, as an example.
Yes.
Classic sort of space, rather than just affirming. Because if we go to the affirmation as a first entry, and we're not just affirming feelings, we're affirming the idea, we're affirming their logic.
Yes.
We're assuming that their logic is therefore valid, that's correct. And if I haven't done my own assessment, that's a concern. And the classic examples I could kind of rattle off is, if a client comes with obsessive compulsive ideas around germs,
yes,
or that the house is unlocked and something terrible might happen, if I just affirm that, I'm not helping the client.
No.
If a client comes in with anorexia nervosa, and they explain that they're feeling overweight and ugly, and I affirm that they're overweight and ugly, I'm actually causing harm.
Yes.
And if I could take that to all extremes in psychology, I think we're, as professionals, being asked to do something much different than blindly affirming, because I think there's major harm and a great departing from a scientist practitioner model, and I'm hearing the same is of great concern, because there's a difference between affirming feelings, affirming a sense of discomfort, because a lot of us can feel uncomfortable in our skin.
Yes.
A lot of us don't like a part of our appearance. But how you then sit with that and make space for that, etc., is probably where psychology lies.
Oh, look, the heart of psychology is questioning assumptions, particularly unconscious assumptions, things that you haven't examined, and they are often at the root of the problems that people experience. And it is the process of stripping away those levels of defense and looking at the reasons that the person with anorexia is judging themselves as being ugly and overweight, despite the fact that they're dangerously underweight. Look, in psychiatry, one of the clearest patterns in the gender-affirming care world is the fact that the WPATH and OSPATH guidelines do not describe how to differentiate someone who presents a gender self-identity, a gender diverse identity, as the result of psychosis, from someone who presents a gender self-identity, gender diverse identity, as the result of some sort of healthy process. Now, I've read in great detail these guidelines. The reason it's not described is they don't have a model of healthy and unhealthy development. So the development of a gender diverse identity is not based on any suggestion that it's healthy to have a female concept of oneself when one has been born a male. What they do is simply say, we're not going to look at that. We're not going to examine that in any way. The problem with that, of course, is that you can't differentiate people who've developed these things because of pathology, and you can't then reinforce the healthy parts of that gender self-identity. So it's a complicated situation, but the way I've thought about it really is there are a couple of big lies that have been told about gender-affirming care in Australia. And the first one is there is no pathology involved in gender diversity. This is literally the idea that any diverse presentation of gender is a healthy variant of norm. There's no way to investigate whether that's the case. It's simply assumed. Now, very much along the lines of what we're talking about in terms of psychology, that prevents a clinician from actually investigating the causes and therefore prevents them from actually treating causes of pathology. Second big lie in Australia is in the wake of what's called the Cass Review. So I don't know if you're familiar with the Cass Review.
Mm-hmm.
So this is big in the area of gender medicine in the last couple of months. It's always been the case that people who are critical of gender-affirming care, such as myself, have looked at the evidence and said, there really is no evidence for any of these things that you're talking about. So the WPATH and OSPATH guidelines literally say there isn't enough evidence for us to base our recommendations on evidence. Therefore, we're basing it on clinician judgment. They literally say, we have come to a clinician consensus amongst this group of people and made these recommendations as a result. In the UK, they had the gender-affirming care was essentially done by the Tavistock Institute, fairly prestigious institute. There's gender-affirming care for minors was done at the Tavistock Institute. They had started along the path of the increasing numbers of people with gender diverse identities about 6 or 7 years before Australia. So they'd seen an exponential increase in the numbers of people. What that means was all of the problems that result from this emerged earlier in the UK than they have in Australia. So there were a number of whistleblowers at the Tavistock Institute. He said things like, well, we have this gender-affirming model of care, but effectively what it means is we don't actually check for any mental health comorbidities. We don't check if they're depressed. We don't check if they have psychosis. We don't investigate whether there's a history of trauma. And therefore, we never find out if these are the causes of the gender diverse identities that they're presenting. On the other side of that...
That's alarming.
That's alarming. Well, it gets more alarming now. I agree, very, very alarming. And to the UK's credit, or the NHS in England's credit, they did react. It did take not just the whistleblowers, but it took a number of patients who'd been through the gender-affirming care model and felt that they'd been harmed to actually take legal action and say, this was not acceptable. Families as well started taking legal action to say, this was actively harmful and we're unhappy about this. So as a result of a number of these cases, they put together what was called the Cass Review. There was an interim report a couple of years ago, and we've just had the final report. And essentially what the Cass Review was concluded was there really is no good evidence for a lot of the practices that are done in gender medicine. It was rolled out at a much faster rate than you would expect, given the fact that there was no evidence. Hilary Cass, who is the paediatrician that ran the review, made a point of saying, if I compare what happened with gender medicine clinics, which rapidly increased in terms of the number of people employed and the number of patients seen over the course of about 10 years, if I compare that to even very successful treatments where there's great evidence that it actually does help people, those other paradigms, the protocols, medical protocols, often take decades to come into practice because it takes a process of informing doctors about it so that they start using it in their practice. So despite the fact that there was really no good evidence that gender-affirming care helps people, it rapidly took off in terms of numbers. So the Cass Review final report came out in March of this year, and there was great hope amongst the group of people in Australia who are critical of gender-affirming care that this would have a big impact because, I mean, you would expect most people to have the same response that you did. If there's no evidence for this, and we know that it causes lots of different harms, surely we should review what we're going to do. But there's been almost no response from medical authorities. So my College of Psychiatrists has literally said, we are not going to respond to the Cass Review. We're not going to take any action. We're not going to, for example, act on the evidence that the Cass Review provided that puberty blockers in particular don't help people at all and often actively harm them. So can lead to infertility in the teens that take them. lifelong infertility can lead to things like broken bones and other sorts of side effects. Lots of different problems with that model of care, but despite that, colleges like the College of Psychiatrists, College of Physicians are not going to even acknowledge that this evidence exists, certainly not going to change their position on this. What that does then, it allows politicians also not to address the fact that these gender medicine clinics have rapidly taken off in Australia, are likely to lead to all of the same problems that they did in the UK. This gives us an opportunity, of course, the Cass Review gives us an opportunity in Australia to prevent the problems before they happen, but we're going to miss that opportunity. So the first big lie that I've been talking about is the idea that there is no pathology involved in gender identity. Very clear that that's not the case. Second big lie is that the Cass Review doesn't apply to Australia because our conditions are different. And this is absolutely untrue. So the clinical guidelines that we use in Australia for minors, for gender-affirming care, essentially have been written by the Royal Children's Hospital in Melbourne, the AusPath organisation. So their clinical guidelines are used by all of the gender clinics around Australia as their model of care, and they directly reference the WPATH guidelines. And the Cass Review also has looked at the quality of those guidelines and said they're unacceptable. They would not be up to the standard required to bring a new clinical guideline into place. So just a complete lie that the Cass Review isn't relevant for Australia's circumstances. Essentially, our colleges, our other medical authorities are just ignoring the fact that there's this paradigm that's been rushed into practice, despite the fact that it harms patients, despite the fact that there's no evidence that it helps patients. And we're just not going to look at it. So your initial response was surprise. Mine is anger. I think that that's completely unprofessional. I'm angry at the College of Psychiatrists, and I think really needs to be looked at.
And appropriate, because what I'm hearing is that anger comes from a space of protection.
Yeah.
There are young people here who are central to this.
Yes.
There's also a community that's kind of standing by and watching.
Yes.
There aren't any voices of at least having the conversation, right?
Indeed.
I mean, I think the idea that I would like to see in rigorous scientific methodology is we get to argue against you.
Yeah.
Right? I get to say, but isn't there evidence that suggests that if you don't provide gender-affirming care, that these young people are likely to go out and kill themselves? I mean, that's a common idea that I've heard. I haven't looked up the research myself.
Yeah.
Is this valid? Because that immediately goes out and says gender-affirming care reduces suicidality, or at least completed suicidality. I don't know, and we should probably differentiate between those as well in terms of attempts versus completions, etc.
Yes.
But that would be a rigorous scientific,
indeed.
At least conversation as a beginning.
Yes.
And we want some fairly strong research before we go out and say, this is what we're going to do. Considering, I think we've already got some pretty good protocols, at least if I talk about psychology, which is to go out and, query these thoughts and this is a process. This isn't it takes time for someone to develop an identity.
Yes.
One that they're comfortable with. I think now in my 40s, I feel probably the most comfortable I've ever felt in my life. But that's probably because in life I've established a few things as well, so I don't have to kind of contend with as much. I know what my roles are. I'm a father, et cetera, et cetera. But geez, it's hard when you're young.
Indeed. Yeah. Well, look, and of course, all of the aspects of your identity are changing when you're young. And one of the concerns with particularly the puberty blockers, but the whole treadmill of gender-affirming care, is that once you get on, you don't get off. Now, if you've got kids who are querying their gender identity, might feel very female one day, very male the next, and you catch them at a point where they are experiencing some gender confusion, and it might be interpreted as gender diverse, you then get a very caring health professional come in, and they focus on that gender confusion. and they ask the child to elaborate on that gender confusion. Now, of course, what they're doing is they're providing attention to that child from an independent and authoritative figure, but someone who's also a caring figure, and providing them with attention specifically because they're talking about gender diversity. Now, you are reinforcing, of course,
Yes,
a diverse gender identity. On the other side, we haven't talked about detransition, but this is the other side of the gender-affirming care. Someone who goes partway through the gender-affirming care process, maybe social transition, maybe taking medications or surgery, and then comes off that and decides, no, I actually identify with my biological sex. That's called detransition. One of the big factors with the gender-affirming model of care, as it's talked about in Australia, is that the detransitioners have almost no supportive networks and certainly no healthcare networks set up to help them. So, of course, not only are you reinforcing a gender diverse identity for a confused teenager who has natural variation, so you capture them at the point where they're most confused and reinforce that gender diverse presentation. Once you've got them accustomed to that reinforcement, they then know that if they stop talking about gender diversity or get off the pathway of gender affirming care, they lose that positive reinforcement. So you're actually putting a punishment in place for them returning to what would have been a normal pathway, which is, up and down in terms of your gender identity. And of course, in the natural history of things, most kids who experience some gender confusion and gender diversity in their adolescent years, almost all of them will return to identifying with their biological sex if they're left to their own devices and don't enter the gender affirming care. So one of the most problematic aspects of the CAS review was that they determined that once someone was given puberty blockers, they became very, very likely to go through the whole gamut of gender affirming care. So just reinforcing that pathway. So
which makes sense because we know as psychologists, psychiatrists that our job is so predominantly focused on supporting a client to see an alternate point of view.
Yes.
And that is so sticky. It's so hard. And this is why we call them core beliefs.
Yes.
Or fusion in the world of ACT. And when we go and reinforce something, particularly when we reinforce it with a medical model saying, I'm going to give you a puberty blocker, that goes out and reinforces that there's something wrong with the way that you are or correct in the way that you're thinking. And so it's very hard to then come back from that.
Yeah.
Like this is what we talk about, people saving face.
Right.
Right. If I lied to you and you catch me out, it's a lot easier for me to say, no, I didn't say that because I'm trying to save face rather than say, you're correct, Ed, this is quite embarrassing.
Yes.
You've now seen my character, which is to lie sometimes.
Yes.
Who wants to say that, right? So it's much easier to say, no, I'm going to maintain my position than go back on my position. So that's scary as well in terms of what affirming means, particularly when it comes from a health professional, because we know about the power dynamic and hence why psychologists have to be really mindful about our language and how we talk in our therapy so that we don't reinforce a whole series of assumptions and inadvertent messages as well that happen in a session.
Oh, indeed, yeah. Well, look, along with that reinforcing quality from a health professional, one of the other concerning things is that there is a political identity that comes along with gender diversity these days. We're in Canberra at the moment, and there have been political protests over the last little while, not just in Canberra, but across Australia, across the world, particularly in the US, to do with what's happening in the Gaza Strip. So young people, they want to be politically active. They want to be part of a movement. They want meaning in their lives. I think one of the unfortunate things that's happened with the gender diverse or, the gender medicine field generally is that it's got caught up in what is a political movement and one that can be quite fulfilling for someone who literally becomes a martyr for a cause. Very attractive pose for a young person to take. So not only do you have a gender diverse identity that we celebrate in our clinic, you're positively acting in terms of the human rights of a persecuted group of people. And on the other side of that, if you leave the clinic, if you decide to detransition, you're betraying all of these comrades that you had. And so you lose the society, you lose that view of yourself as part of a very virtuous cycle. So these are all very self-reinforcing aspects to gender-affirming care. It is a very insular culture as well. I've written a couple of papers on this, which basically talk about the fact that we find it very difficult to get any information about what's going on in Australia's gender clinics. The Cass Review had a couple of interesting points to make about this. They basically said, well, we really wanted to look at the impact of gender-affirming care on the kids after they'd left the youth clinic and were being seen by adult clinics. They weren't able to do that analysis because the adult clinics refused to give them the data. So they were basically, I mean, very surprising, of course. And you would think that if they had evidence that gender-affirming care helped them as adults, they would have been very willing to provide that data, but they weren't willing to give that, which suggests that maybe the results weren't particularly good. It's come out in the last couple of weeks as well that the WPATH organisation had set up some systematic reviews to look at the impact of gender-affirming care, got the results and haven't released them. They've refused to release those results. So there's really this insular culture, both within the medical professionals, but also the kids that are going to the clinics, that almost cuts them off from outside influences. So one of the biggest problems that we see with this is the families of kids who start to identify as gender diverse. There are literally online forums where professionals who provide gender-affirming care are talking about this, and they basically say, if your family doesn't instantly affirm your chosen gender, they're essentially traitors to you and you should get rid of them. So literally as bold as that. And certainly in Australia, we've got a number of people who are speaking out about this, people who have essentially lost contact with their sons and daughters because of that sort of attitude. I've had some fairly tragic cases where they have gone on to commit suicide. So look, a very insular culture. It reinforces the isolation that you'll feel if you leave the culture, because of course you've left behind the more average society, if you like, to go through this gender process. And then you would also be, if you go back to that normal state of things, you'd be losing this new culture. I do want to mention, you talked about the idea that gender-affirming care might reduce the rate of suicide. This is one of the things that was found by the Cass Review and other books by Hannah Burns and other people. Almost a sort of emotional blackmail attached to the idea of suicide. So the phrase that's commonly used in the media is, would you rather have a live son or a dead daughter? And the idea there is gender-affirming care is such a life-saving treatment that if you don't provide it for your son or daughter, they're going to kill themselves with high certainty. Now, this has never been the case. There's no good evidence that being gender diverse in and of itself increases the rate of suicide. And there's certainly no good evidence that providing gender-affirming care reduces that rate of suicide. There's a recent study from Finland, which is the best evidence we have about this. There is an excess rate of suicide in the class of people who do identify as gender diverse, but it's entirely explained by the comorbid psychiatric conditions that they have. So certainly true that people with, transgender, non-binary and so on, experience higher rates of depression, higher rates of anxiety, post-traumatic stress disorder, and these other conditions. Asperger's is another diagnosis that commonly co-occurs. And the higher rates of suicide are explained by these other conditions, not by the gender diversity itself. And by the same token, providing gender-affirming care then doesn't reduce the rate of suicide in these kids. So very common idea, used as a tool of emotional manipulation. I don't think, I think the people who say this genuinely believe it, but of course it illustrates the real danger of setting up these gender clinics, despite the fact we don't have good evidence, people can very confidently tell a family, if you provide gender-affirming care, it's going to reduce the risk of suicide in your son or daughter, when they don't know that. And the reason they're saying it is because they've been told it's true based on no evidence. So just a good illustration of the dangers from setting up medical protocol on the basis of very little solid evidence.
It almost brings us back 70 years ago, where we were very certain that people who were attracted to the same sex had something wrong with them, and we need to go out and,
Yes.
pray it away, or put them through conversion therapy, or whatever nonsense we brought at that time.
Yep.
Because clearly we weren't questioning it.
Yeah.
There was a strong, maybe there was a political flavor at that time to say we shouldn't tolerate that.
Yeah.
That's not okay. And so we won't do the research. We don't need to do the research. We don't need to go out and do that type of scrutiny.
That's right.
So we'll abandon the scientific method.
Yep.
And we'll set up some clinics, and
Sure.
we'll work on it that way. It's almost like we're back there where we're not at least even having this conversation, querying it. Because I don't think anyone's saying, should we abandon these children?
No.
Should we go out and not give them support and care? Should we neglect their needs?
Yeah.
No one's saying that. The question that we're asking here is, what's the best way?
Yep.
And is affirming, should that be our first line of treatment?
Mm.
In the absence of what should we do, I would actually say there isn't an absence of what should we do. I think that psychology has this covered under its current understanding of human behavior, and what to do when there is confusion.
Yep.
Maybe you could argue that, but I would like to think that argue it with science rather than us just going out and having a different points of view.
No, indeed. Well, look, and this is why the CAS review and the response to it in Australia is so important, because essentially people in Australia who want to continue with gender-affirming care are not only saying we should ignore the results of the CAS review. I mean, I would say the CAS review results are entirely applicable in Australia, but they're not only saying we should ignore those results, they're also saying we should not do a similar review in Australia. We should not even look at the evidence. We should not review what we're doing and make sure we're not making the same mistakes in the UK. And yes, as you say, if you don't follow the scientific method, you're not ever going to improve your practice. So it's certainly not high quality care. I think that the issue of homosexuality is an interesting one. It's illustrative. I think there is an element of guilt in the psychiatric profession because we were instrumental in the persecution of this group of people, as you say, not based on any evidence. It was, of course, socially imposed mores. So it wasn't just psychiatrists who thought that this was a perversion. It was a common belief throughout society. It doesn't make it right, but that's the reason it existed. I think it's really interesting to look at how that problem was solved. The only reason that we don't think of homosexuality today as perversion is because there was a broad society-wide conversation, and we essentially came to the understanding. The reason we came to the understanding was not because psychiatrists particularly had a strong role, but society itself came to believe homosexuality is not a disease in any sense. If you have homosexual relations with other people, you can have perfectly healthy relationships with them. Arguments were made about things like perverting youth and so on and so forth. So none of those things were true. They were just assumed. And because they were assumed and never examined, we never actually overturned those beliefs. Exactly the opposite is now happening with gender diversity. We assume all of these, or at least WPATH and OSPATH assume all of these things and don't allow anybody to question those assumptions, and therefore the untrue assumptions can never be overturned. So we really need to question those assumptions in order to make positive progress. I absolutely agree with what you said, which is psychology and I think psychiatry are already sufficient to deal with these issues. You really want to facilitate the self-exploration of each individual of the reasons that brought them to you. Gender identity might be part of that. Trauma might be part of that. Just the natural stressors of adolescence are likely to be part of that. Of course, the family situation is going to be a huge part. And I think the separation of kids from their families is one of the most harmful aspects of gender-affirming care as it currently happens. Because essentially what you're doing is you're giving children the capacity to prevent their parents from having any authority in this area of their life. If you say, I am transgender, non-binary, a eunuch is one of the newer ones, and your parent cannot question that, you now have a mechanism for shutting down any debate. And of course, kids love to have that mechanism for shutting down debate. It gives them control that they don't have in any other area of their life. Now, if you have a hammer, everything becomes a nail, and often all of the other stressors in family relationships will then be mediated through gender diversity because the kid knows this is the ultimate conversation stopper. That will then force them away from their parents, or if their parents accept what the health professionals are telling them, they then lose all of the control in the relationship. Parents should have control over their kids. Now, there is a gradual process of the kid moving away from that control. But what gender-affirming care in this model does is it puts an artificial stop in that control and gives the kid ultimate control over all of those situations. Or, as I said, it removes them from the situation entirely. So look, just a whole number of ways that this is harmful, not just for kids, but also for the families that would like to support them. And as we talked about at the beginning, really broader society, I think, is paying a price for this. Blurring all of the boundaries between sexes, between the sexes is not a good thing. Kids actually respond to firm boundaries and they respond to the adults around them having authority, being sure about themselves, and providing guidance to them about where those boundaries lie. So a lot of different ways this is harmful.
And the research is so clear. That's not even questioned in terms of parenting styles and boundaries and the like. But so many concerns there in terms of saying children should be taking the lead.
Indeed.
We should be isolating children from stable supports in their life. And the other thing that jumped up for me is there's also another concern about the potential, and I haven't even thought this through, but it'll be good to throw this backwards and forwards, is almost the possibility of a Munchausen's by proxy type of scenario going on, because I know that there are some strong advocates of how their children should be treated and who their children are. I know they're a super minority, but that's going on. So is the Munchausen by proxy numbers are low, but it occurs.
Oh, indeed.
And this model of care of saying affirmation first does not go out and say what's the environment that this child is in, and we kind of say we're just going to follow their voice, which is just actually a repetition of their parents' voice.
Exactly.
It's no different to brainwashing, if I can just use that, of a political idea. Let's use the Gaza scenario.
Yep.
I imagine that if we took a child who was 10 years old and they were told from a very early stage to say, the Palestinians are terrible, or let's do the inverse and say, it's the Israelis that are terrible. I'm Serbian. If you imagine what's happened in former Yugoslavia, you can tell a child anything you want and they will just repeat it.
Yes.
Right? And we do this in loving ways, like go the Canberra Raiders, they're the best football club, or, AC Milan or something.
Yep.
And the child just takes it on.
Yeah.
This is much more concerning because it potentially leads to, serious questioning of what is my sex?
Yep. Oh, absolutely.
And if we blur the lines of sex and gender, then that makes it even more complicated.
Oh, indeed, yes. Well, look, and we've talked a lot about societal implications. One area we haven't talked about is schools. And one of the areas I'm most concerned about is the expansion of this perpetuation of human rights to the detriment of human health into the school system. And so one recent example I've written about is the South Australian Education Department has put out a mandate that has said that a child can transition at school even if both parents disagree with that. Now, they do have to notify the parents that this is what they're doing, but the decision as to whether it is in the interests of that child socially transition at school is not made by a health professional. It's made by what's called a site leader. And I found this interesting, so I asked about this. Site leader is essentially someone like a principal. Now, a principal has no medical training whatsoever. They don't have the capacity to do the sort of investigation that you would need to say, well, this child has what we call in medicine the capacity to consent to this. Social transition is a medical procedure. Again, the Cass review did say you cannot assume that social transition is a benign process. It certainly has lots of harmful implications for social and developmental characteristics of the child. So the fact that a site leader with no medical training, no health training, can then potentially make a decision that this child is going to socially transition despite both parents not wanting it. So effectively, the child is going to socially transition at school and not socially transition at home, to me is just complete insanity. The idea that medical practitioners find it very difficult to make a good informed consent process with these kids. They're confused. The area is not particularly well known. And often there are other things going on in terms of mental health that make it a very difficult decision. They're sort of often on the cusp, between 12 and 16, where they're emerging into a more autonomous state, but very difficult decision to make. So the South Australian Education Department then has put this mandate in place where non-health professional with no training is making a decision that a medical professional would find very difficult. Even worse than that, the WPATH files was a set of online forums from the people that put the WPATH standards of care together. And it was clear that even the people that wrote the guidelines find the informed consent decision to be a difficult one to negotiate. They often didn't know whether this individual kid in front of them had the capacity to consent to these procedures. So the idea that a school principal or some other school leader is going to be able to make the decision is, as I said, completely insane.
I tell you what, the problem with consent, actually, let me step back one moment. I'll come to consent. I'm feeling angry.
Oh, yeah.
that what you were talking about, like my heart rate's gone up.
Yeah.
As a parent, saying you are pulling me out of my child's welfare.
Yeah.
And you're starting to, put the state in front of of that. That is horrifying to me.
Yeah.
That is so scary.
Yeah.
The other thing I wanted to raise, when I start thinking about, having this conversation, we should even be querying about what is the facts in terms of definitions that we talk about in schools, because I think our biology, our science, our physics should be fundamentally understood if we're going to be teaching them to children as facts. We should definitely understand, how gravity works and the like. If we're going to be explaining it to all, and if there isn't consensus, then at worst, we should say there isn't consensus and have a conversation, and that would be inquiry, curiosity. That's how we want children to be exposed, rather than saying this is a factual thing, because children are impressionable. But let me just quickly come back to consent. I've jumped a few little things. I would love there to be the importance of consent that is established unbelievably strictly, because consent that can be established strictly, I think, will open up to a legal question. How did you establish consent?
Yes.
Because at that point, if you're going to be doing something with a child,
Yeah.
particularly when it comes, probably not so as much in my work, and that's probably where the boundaries can bleed and still reinforces, but certainly in the very medical world, how did the child understand that puberty blockers could potentially, and in some cases likely, mean that you are sterile and you will never have a child? And how will you feel about that at age 20? How will it be at 30? How will it be at 35? How will it be at 40? How about 45 when the likelihood is so low that you could now? Well, how did you experience that before? How about if your friends have gone? You have to have a very thorough conversation. I would imagine that's probably going to be 50 sessions worth. And it might need to mean that they get to age 18 before you can do that.
Sure.
Before at least they can legally say, I'm happy to make a decision in my life that has irreversible consequences or affects that are now, as an adult, am willing to bear. And obviously, we could debate whether 18 is the right number, but for all effective purposes, it is in society. We've given that number.
Yeah. Look, I agree. A lot of the focus is on minors, and I think for this reason.
Absolutely.
Do they have the capacity? My opinion, my broader opinion, I think that the from a medical point of view, the lack of a definition of what gender identity is, so there is no good definition of gender identity in the WPATH standards of care or the AusPath guidelines and similar documents, by definition means that you cannot say what gender diversity is. So if you don't know what gender identity is, you don't know how it develops, you don't know how it develops in a healthy way or an unhealthy way, you cannot then say, well, there is a diagnosis associated with this. You don't have a construct in any sense. So if it's not understood by a medical professional, by definition, it cannot be understood by a child. That's independent of the consequences you're talking about.
Sure.
Yeah, very, very clear consequences, puberty blockers and leading on to sterility in many cases. Even, as I said, the WPATH files was this release of the online forums where the people who developed the WPATH were discussing, how they were developing their guidelines and what the implications were and those sorts of things. And it was clear that many of them actually didn't think that their kids had the capacity to consent, but also that it was very nebulous as to which ones did and which ones didn't. And a number of them accepted. It's literally impossible for a prepubescent child to understand what childbirth is. The natural reaction is, that's gross, I don't want to think about it.
Sure, they're kids.
But even so, those kids of that age are being given these medications, which sort of demonstrates there's just a complete dissociation from scientific evidence and what is, as I said, a claim to a political right. So the reason these people are willing to harm children, and that's what they're doing, you give a kid a puberty blocker, you are harming them. You're putting them at risk of sterility, for example. The reason they're willing to put their health at risk is because they think it's worth it to gain the political right. They think it's more important that you are able to express your gender identity, that you have the right to that, than that you receive competent medical care. And that question of consent then is one of the things that they are willing to forego. It doesn't matter. They think it's more important that you have the right to gender self-identity than that you have been given the capacity, that you have made a valid informed consent for this process. So it's as nakedly political as that.
And then what happens to the child who says, I no longer identify?
Yeah, exactly right. Well, as I said, in Australia, no good pathways for detransitioners.
Yeah.
So I've spoken with a number of these people who, the sense of abandonment that they feel is just extraordinary, because they often, there's a lot of talk about things like authentic self and all this sort of stuff. So that by this process of gender-affirming care, you have come to know your authentic self. And these people are giving you lots of positive, unconditional positive regard. And even then, you find you're still very unhappy. And of course, you've gone through a fairly, there are sunk costs, as they say. You've done things to your body. You have irreversible changes. These are all things that if you were wrong in that initial decision, that you probably shouldn't have made because you didn't have the capacity for it. But if you were wrong about that decision, you have now harmed yourself.
Sure.
Yeah. If you turn away from this path, you lose all of that support. You're left alone with your bad decision and your harmed self. Often you've lost the family and the other supports in your life, and there is no clear path for detransition. I was stunned to find that the word detransition doesn't actually appear in the AusPath clinical guidelines for minors. They do not address it. So the assumption is once you are on this pathway, you will continue on this pathway. Well, yeah, which is just, you might be feeling angry again, and certainly makes me very angry.
I can't shake it.
Yeah.
I can't shake it. I can see why you're so passionate about this. What do your colleagues say? And maybe I should ask, what do they say to you privately? And what do they say publicly? Because I know that there is a concern to have this conversation. It's a bit anxiety provoking. There's fear of being name called or something, or put in public that you're a terrible person, whatever it might be. What does your
there are two groups essentially, Nesh, and one group I think essentially looks at this the same way that I do. They're stunned that the profession hasn't taken a stand on this. Somewhat angry, somewhat ashamed. I think it's shameful that the profession of psychiatry in Australia and elsewhere hasn't taken a stand. There's another much larger group who don't want to address it in any shape or fashion. And I've been thinking quite a lot about this. I think there are a number of different reasons for this. One, I won't say more legitimate, perhaps less illegitimate reason. Most psychiatrists don't treat people with gender dysphoria, and they don't feel that they can necessarily have an impact. And on the other side, they think that there is risk to standing up and taking a stand. One of the reasons they think that is because the gender-affirming network is very powerful and organised and can have lots of negative implications for your career if you start talking about them. The most visible example of this is a colleague of mine, Gillian Spencer, who started talking about this. She was a psychiatrist at the Royal Children's Hospital in Queensland, and essentially got kicked out of her job, basically for raising questions. That still hasn't been resolved after a year, so she's going through various legal actions. Most other
what sort of questions?
Well, essentially the questions we've been raising. So puberty, she was saying, for example, puberty blockers are harmful. We don't have any good evidence that they help. If this is the case, why are they part of our medical protocol? Why are they part of the protocol for the gender clinic at the Children's Hospital in Queensland for gender-confused teens? Now, that is a reasonable question. If you ask that of your hospital, you would think that they would give you a reasonable answer. But at least ostensibly what they did was to remove her from her position and say you cannot work in the Children's Hospital in Queensland because you've raised these questions. Now, this is probably a more complicated situation than I'm aware of. Sure. I don't have all the details of the legal ins and outs, but at least in terms of what's been reported publicly, that is the situation. So yeah, as I said, there's this other group of psychiatrists who really don't want to talk about it. They don't think that they can have a positive impact, and they think they might be harmed as a result. I actually ascribe most guilt or shame or criticism to medical authorities, and particularly College of Psychiatrists, my College of Physicians, who are the people that originally endorsed the gender-affirming care model and basically said, yes, we think this is the right way to go. College of Physicians still takes that position. The College of Psychiatrists originally endorsed the model and then stepped back from that. They don't condemn or criticise the model, but they have changed our position statement to now say there's no good evidence that this harms or helps kids. I think that we have a responsibility to go the extra step and say this is an actively harmful protocol for all of the reasons we've been talking about. And I have formally asked the college to do this, and they have said that they're not going to do that. So, I mean, if I looked at the
But
rationale,
if we don't have the evidence for or against, but you will still provide puberty blockers that have irreversible damage.
Oh, absolutely.
And like all medications, there's a balance between what's the desired effect versus what's the side effect.
Yes.
And you weigh those up depending on what you have to make a decision. How do we go and say something that has irreversible and that can't be harming versus saying we should actually say we oppose that until we get, it's not opposing it indefinitely. It's imposing it until, we oppose it, my apologies. We oppose it, not indefinitely, but until we get further research that demonstrates its efficacy. And if the efficacy is there, then great. We've got good, robust scientific methodology that we can go out and follow and point to.
Yeah. Well, there is a reason for this. I mean, this is speculation. I don't have direct report that this is the case, but nothing else really makes sense. Not only are they not opposing the model, the College of Psychiatrists, College of Physicians and others, they have, as I said earlier, they have ignored the CAS review, and they have said, despite the fact that we've got this good evidence that puberty blockers are actively harmful, as you have said, we are not going to ask for that research to be done. Now, effectively what they're saying is, these gender medicine clinics are all around Australia. The numbers are exponentially increasing. We don't know whether they harm or help kids. You would think that a professional medical authority would then say, we need to have the evidence as to whether they help or harm kids. They're not willing to say that. Now, if you were to speculate on that, I would point back to that strategic manifesto, Only Adults by Dentons and Thomson Reuters. The attempt is to avoid scrutiny, and the mechanism by which you avoid scrutiny is to infiltrate organisations that make decisions. You don't convince the public because the public does not like the idea. You focus on the few people, so that would be MPs and so on in parliaments, but also the people making decisions in College of Psychiatry, College of Physicians. You really just need to get 4 or 5 people onto the right committee, and you can prevent the college from taking that sort of stand. And I mean, as I said, I haven't been involved in these committees, but I understand that is exactly what's happened. This is called institutional capture. Sounds a bit conspiratorial, but if you think about it, there's no really good reason why a college of psychiatrists would not be calling for further investigation. There's no harm in it. Even if you believe that gender-affirming care works, calling for further investigation really would just confirm that it works. There's no downside to that. So the fact that they're not calling for that, I think, is a pretty good indication that the people making the decisions, not all of them, but enough of them to make a difference, have decided, I'm more interested in the human rights of this group of people than I am in the harmful health effects of this particular protocol.
That blows my mind.
Yeah.
I know that when we had, I hope I remember her name correctly. I think it was Isabel Mirabelli. That was our APS president for a period.
Oh, yeah.
And I know that she was advocating, or at least putting forward an open conversation with government about saying, let's measure the value of psychological support.
Yep.
So that we can actually base it scientifically on what do we provide.
Yeah.
Which is, I think, quite a gutsy move, so to speak,
Yes.
because you're going and saying, we're going to put our money where our mouth is.
Yeah.
We're going to test it. And if we don't have the value, if we don't put the value forward or demonstrate the value, then you should take some of the budget away from us.
Right.
Because that would make sense, right? Versus if we do demonstrate that we've got value and efficacy and we're seeing a better result, in terms of mental health in our community, well, then that would obviously mean give us a bit more money.
Yeah.
For example, let's go more than 10 sessions a calendar year.
Yes.
So I thought that was great, because that says we are open to scrutiny.
Oh, yeah.
And if we're not doing it well, then we need a body saying, hey, psychologists, you need to do better.
That's
we
right.
need to improve our training. We need to look at our research again. We're going to go back to our protocols.
Yep.
But we've got to ask really meaningful questions about how well is our industry doing its job.
Yes. Well, the biggest problem with that idea, as I said earlier, is that it is not the goal of gender-affirming care to improve mental health. So they're not measuring, for example, depression. The outcome of going through gender-affirming care is not, we expect rates of depression to decline. It's literally the goal of gender-affirming care is to affirm gender. That is the only.
That is it.
Yeah, that is the only outcome that is expected from the WPATH, the AusPath guidelines. The result of that, I mean, the APS past president may have been right that that would be a good thing to do, but the result of this model of care is that there is no measure like that that you can go to. Really, the only measure is, well, you go to this person and say, well, what's your gender identity today? And of course, the way that the guidelines are written, persistence of gender identity is not a measure of success. So essentially the way that they're conceptualizing gender now is a spectrum of experience that doesn't have to be constrained by biology and also doesn't have to be persistent. So the non-binary and gender fluid are a couple of examples of non-binary. Means that you don't have to have primarily female, primarily male characteristics. You can have a combination of those. So no real differentiation between different categories. Gender fluid means your gender identity can change from moment to moment. There is no stability to it. So if that is the case, if you have a protocol that the only goal is to affirm the self-reported subjective identity of a person, and that as part of the model can change in a healthy way, there is no measure that you can take that says we have actually succeeded.
Yes.
Yeah. The only measure then is, are we giving people the treatment that they're requesting? That may, of course, that may be for healthy or unhealthy reasons, but that is the model as it exists. So look, the APS past president's suggestion is a good one from a medical point of view, from a psychological point of view.
Brave. It says we believe in our product. Yeah. So we're open to scrutiny.
Yeah. But of course,
but in this sense,
it's irrelevant to the gender affirming care model.
That's right, because if the measure, and obviously the measure would be the most important part of this, if the measure was, do we provide kids with affirming care? The answer would be yes, you do.
Yeah.
You do that exceptionally well, right? So you've done affirmation. But if we're actually asking, do the depression rates go down?
Yeah.
Do they feel more stable in their identity? How do they do emotional regulation as adults and et cetera? Then that would be a much more robust way to look at whether there is any validity in this.
Yeah.
But it almost feels like it's almost like we've been lost in the semantics of this anyway, because I think we should go back all the way to the definition.
Oh, absolutely.
Because otherwise we're in this space of, if we're doing affirming, we're just saying whatever I feel, I need to be affirmed on. Like that's what children do.
Exactly right.
Dad, I want an ice cream.
Yeah.
Oh, here you go, dear. Well, now I want Nutella. Here, I want some lollies. And then the dentist goes, what's wrong with your teeth? Well, nothing. Like, I'm just giving my children what they want.
Exactly.
There's a problem there.
If you look at, I agree.
And I don't want to minimize this in terms of, obviously there are young, there are kids in here who are deeply distressed.
Yes,
right?
yes.
Deeply confused. So I'm not minimizing the experience. And I tell you what, if I can just jump back a bit.
Sure.
Whenever I have these types of conversations, it's almost like I have to put all these caveats around,
yep.
Right? Because it's kind of like the scrutiny of, as though as a psychologist, and I've treated thousands of people with great love and care, as I do all human beings. But I kind of have to say, please, I'm on record here.
All right.
Right? I do care for these people. There's this kind of funny thing about the fear of, are you allowed to talk about this? Are you allowed to care about children in with your view?
Yeah, right. Yes.
And this is just about saying, I care about children, and I think I'm more deeply concerned, having had this conversation. I care about children in my way, and I have a belief system around that. I believe I'm trained well enough, and I've got at least my ideas packaged in a particular way that I think resonates with logic and reasoning, but I'm open to scrutiny and being questioned.
Yep.
I'd love to start at where we started. Our first point of the conversation is, what are the definitions? Because that's primary.
Yes.
I think I've lost my thought there. I'm just getting a bit. I was stepping back, saying I have this kind of concern that I have to caveat that I'm a caring and loving person.
Sure.
You know, that I'm not this awful, terrible human being that acts in a psychologist role and is just going to go out there and harm everyone. That I'm insensitive. You know.
Sure.
It's interesting that that's my human response, right?
Oh, indeed. Well, look. In some ways, this whole paradigm is the natural extension of that way of thinking. If you look at some of the older models, particularly of CBT and related, cognitive therapy, they were quite brutal, and they thought that they needed to be quite brutal. That may have been part of the society that they were in, but in some sense, this has emerged. This whole area of gender medicine has emerged out of an inability to say no to people or to set boundaries on their experience. What I think the problem is a failure of integration. This is literally an inability to integrate the female and male aspects of the identity, because everybody has some.
Absolutely.
Yeah. This is something that you are, as part of the natural developmental pathway, not necessarily consciously, but unconsciously you develop as you get older. By the time you're an adult, most people have a fairly strong sense of themselves as male or female, and they will have integrated, let's say you're a smaller male, you will have integrated the idea that, well, there are lots of males who are taller than me, that sort of thing. As a female, you might be heavier or some other aspect of femininity that's important to our society. You need to integrate that negative aspect of the personality and accommodate it, and there will be checks and balances within each individual personality. So I think what's happening with gender medicine generally is a failure of that integration. We're dissociating male and female aspects of the self, and we are forcing people then to pick one, if you like, or in terms of gender fluid and non-binary, basically say there are no standards. You reduce anxiety by saying there is no standard against which I need to compare myself. Everything is okay. Nothing is bad. And those are equally dysfunctional ways of solving those problems of development. So I'm not sure they're classic definitions, but that's the problem as I see it. Until we can conceptualize the psychodynamics of people presenting with gender confusion with an understanding of healthy and unhealthy development, we're not going to get a successful model of treatment for this area.
And I hope we can get to a place where we can continue this type of conversation. Yeah. I remember when I was first exposed to acceptance commitment therapy, I jumped on the bandwagon because I was so excited, right? Oh, yeah. I'm all in. And if you're all in, you're therefore against CBT, right? Because you shouldn't be, by any stretch of the imagination, doing logic and reasoning and challenging.
Right. Okay.
Right? So challenging was a problem.
Yeah.
Rather than observing the thought and deciding whether it has utility or not. Is it a helpful thought? Is it an unhelpful thought? Truth be told, that's a really naive way of a young clinician going, this is the best, so I'm going to reject the other.
Right.
Right?
Yeah.
But obviously, as the conversation evolves, and if we look at the two camps, the CBT space is actually not against the ACT space, and the ACT space is no longer against the CBT space. There's room for understanding and conversation and the like, and we actually find that they're more alike than they are different. They're actually more semantically interesting in terms of when you start pulling it apart. There are some differences, but we can still see how they lean in the same direction. And what I'm hearing here is the conversation has been shut down, and we should have an opportunity to continue the conversation. Yeah. So if I've got it wrong, I can have an opportunity to change my mind.
Yes. Yeah.
Right. Because mate, I get so much wrong. Right? I get plenty wrong. But I've got an ability to change my mind.
Yes.
Right? Similarly, children change their mind.
Yeah.
Right. They say they change their feelings.
Yeah.
I feel like this today.
Yep.
In a year's time, I feel different. Right? So we have an opportunity to change our mind. So I hope this is a conversation we can continue in society and not just say this is terrible and you're on one side. I obviously lean in that scientific method, and I believe that's valid still in this topic, that affirming care is not necessarily the right model. I think psychology and psychiatry have got this covered in its most traditional sense.
Yep.
But maybe for our listeners, where can people continue this conversation? Where can people find out more about your papers, about what the models available are for those who are going through gender confusion or questioning their identities?
Look, for my work, it's pretty much all available online. The two sources where I've published most would be journal Australasian Psychiatry. So if you search for Australasian Psychiatry, Andrew Amos, and gender, I've got 5 or 6 papers that will come up on the topic. I've published a number of opinion pieces in the Australian. So again, Andrew Amos, the Australian. So looking at the politics and the clinical side of things, a bit of the legal side of things. If I was going to encourage someone to read one document, I would encourage people to read the Only Adults document by Dentons and Thomson Reuters. It is a 60-page document, which may put some people off. There is an executive summary. The reason I would encourage them to read that is because it lays out the strategy that is being used to promote this ideology across the world. And I think if you read that, you'll have a better understanding of why this thing has progressed so quickly and also what is needed to change it. So really, we need to convince politicians. And in order to convince politicians, medical authorities need to stand up and be counted. So those would be the things that I would get people to look at. Australasian Psychiatry also has put together a special collection. So Gender Medicine is the title of it. So if you type in to Google Australasian Psychiatry, Gender Medicine, we've got about 20 or 25 articles in that collection that explain clinical aspects, legal aspects, and philosophical, ethical type side of things. So that's a nice place to start.
Yeah, wonderful. Look, it's an incredible conversation to have, because it's a place of, I think, intense confusion.
Yes.
And why it interests me so much is because for me, it feels like some of the fundamentals that I have so much held and cherished that forms who I am. It almost questions my identity if I don't have these conversations.
Yes.
Because I want to question. I'm curious.
Yes.
And when something doesn't fit, and when it doesn't fit so far away,
yeah,
to just purely say to children, whatever you say, that just in its first instance just doesn't feel right. Now, don't get me wrong. I was the first to argue with my parents. I had a strong spirit, and I continue to do so. And I'm still happy to argue with them on occasion. But this is not really, I think, about arguing. I think this is actually about having open dialogue.
Yep.
That is in a condition of consideration and methodology and thoughtful, where two professionals, I would love to hear the other side.
Yes.
In a calm way. You see everything on the media, people just attacking each other. That's called entertainment. And sadly, all the information is lost because we don't get to ask more robust questions. So when you say, gosh, 60 pages, I would say read the 60 pages. Take your time.
Well, there is an executive summary. So if you don't like 60, read the first couple.
Because that's how you inform yourself.
Yeah.
Likewise, read the arguments for and read the arguments against.
Yes.
Because that's the way to inform
Yes.
and to observe your biases.
Oh, indeed.
I know I've got biases, and so it's hard for me to hear the other side and adopt it because, as I said at the very beginning of our conversation, my bias is if someone has a penis, they're a man, and I see that biologically, and I don't see that shifting.
No.
Right? That's my bias. And so I need to be upfront and openly say that. If I'm attacked for that, fair enough. And I'm happy to change it if I've got compelling evidence in front of me that's what a good scientist practitioner does. They change their mind.
Yeah.
Right.
Yeah.
And we saw psychiatry do that with persecuting gay people.
Yes.
And lesbian people. And thankfully, we're in a very different world where we
Yeah.
celebrate gay and lesbian people. As a matter of fact, I believe we celebrate everyone. Some of these ideas still need to be questioned.
Indeed. No, I agree.
Andrew, thank you so much. It's been a great pleasure, and it's been very insightful as well. So appreciate your work, and I would just wish you all the best in maintaining this conversation for all of us.
Fantastic. Well, thank you, Nesh, for being such a great interlocutor. Very interesting conversation.